I'm going to present a case of valgus knee. So this is a 72-year-old lady with pain and deformity of left knee since 5 years and difficulty in walking since 2 years. So this is the clinical photograph. And this is how she walks. So there's a valgus knee, and you can see some deformity at the foot. There's a plantar valgus deformity.
All right, so let's stop there. Peter, why do valgus knees present with such large deformities?
Why?
Yeah.
Well, it's a combination deformity, I guess you could say. I mean, a lot of times you have a foot deformity, right, which can make it worse. So it's a combination of flat foot deformity, external rotation, and then they just progressively stretch out and then get bony erosion.
So what about pain compared to varus knees? Which hurt more?
We say that valgus knees hurt less than varus, but valgus knees hurt as well, but oftentimes valgus knees will have more buckling, giving way, mechanical problems, and varus just hurt more with ambulation. I think we do see that.
Yeah, so I mean, I think he described it well in the history, right? She had a hard time walking. Right? That's what varus knees, and that you all see in India, they can still walk. Yeah. Right? So varus knees, we operate on varus knees for pain. But we operate on valgus knees because they lose the ability to walk.
Yeah. Especially the women, the thighs tend to bump into each other. The clearance is not there. That's the problem.
All right, keep going.
So there is a 15 degrees of valgus, which is partially correctable, and there is no sagittal plane deformity. And the hip and spine were normal and no distal neurovascular deficit. And these are the X-rays.
All right. Where's your merchant view?
Oh, sorry, I couldn't add that.
Okay. Is the patella tracking in the groove?
No, it was lying laterally. Actually.
It was lying laterally.
Yeah.
All right. So who's Dr. Tapasvi, we'll start on your end. Standard medial parapatellar approach? Yeah.
Yeah. For me, this is a medial parapatellar approach for sure. One, minimal medial release. Remove all the osteophytes on the lateral side, both femur and the tibia. This is one place where you really want to go right around the tibia on the lateral side and then reassess the deformity. See if it is fully correctable or partially correctable, both in flexion and in extension. And depending upon whether it is tight in both extension and flexion or tight only on flexion or in extension, then start making the necessary releases. So typically for extension tightness, the releases are going to be of the iliotibial band and the anterolateral capsule. For flexion, it is going to be the posterolateral capsule, which needs to be released. And if it is absolutely not correctable, which is not obviously in this case, which is if it's a fixed valgus, then I don't spend time trying to do all these releases. I go away straight to a lateral epicondylar slide osteotomy.
Okay. Does anybody have a different opinion?
I was going to add the popliteus, a little pie crust for flexion tightness before lateral epicondylectomy. So I think that gives you, nice balancing option.
All right, so raise your hand. Who's doing who's considering a lateral epicondylectomy for this deformity?
For this?
Yeah. No. Nobody is, right? Okay. Yeah. I mean,
this patient also has a hyperextension from the way she was walking.
yeah.
So that's something that you need to factor in, and a high riding patella. Yeah, so that's something that you need to factor in terms of making your distal cuts.
So how are you going to manage that? You brought it up, so how are you going to manage it, Dr. Rajagopal?
I would distalize the femur.
So you're going to not over-resect the distal femur.
Yeah.
Are you going to do anything post-operatively, maybe bracing or?
I would aim to get this knee into about 5 degrees of flexion at the end of my surgery.
So you're going to try to build in a slight flexion contracture intraoperatively, okay.
3 to 5 degrees that eventually would stretch out. And even if it did not, you'd still have a very stable construct.
It's more likely, probably it's the bony erosion that is giving the potential gait hyperextension. Have a look and then probably go with the normal way.
Yeah, I mean, I think once you have your trials in, you can see, you just hold the foot, and if it's hitting the post in the front, you got to do something to fix that. All right, why don't you tell us what you did? Yeah, go ahead, Mania.
So the only other thing is what you brought up earlier, the patella is not right in the center, and so I'll be very careful in adjusting my rotation. And if it still remains out, then I would do a outside in lateral retinacular release in a step manner to bring it back.
What's true about this case, it's already has patella alta, and then you distalize the femur, and then it's not even captured in the trochlea.
Yeah.
So you got to be careful, because if it's above the flange, the button can shear off. So you can't distalize too much.
Yeah, I mean, I probably would cut it at like 8 millimeters, not 10, but I'm not doing like 5 or anything like that, right?
So what would be the choice of implant, Amar, here?
That I would do?
Yeah.
I would do a PS knee.
Medial congruent.
Anybody, you want to do a CR knee? All right, 2 CRs, 3 CRs?
And medial congruent.
CR with an ultracongruent insert.
All right, I mean, I think that's absolutely fine. And you may have that advantage if it does become a little hyperextension. That's an advantage. The PS that's actually a downside to that, right? All right, so tell us what happened next.
So I went through a subvasous approach, a slight medial entry for the femur, and minimal resection from the tibia and femur. I initially released the iliotibial band and the posterior capsule, but the
Okay,
tightness.
so when you say you released it, you completely released it, or you pie crusted it, or what did you do?
The ITB I pie crusted, and
Okay.
the posterior capsule I released.
Okay.
And then there was tightness still in flexion. So I did a sliding lateral epinodal osteotomy, and I implanted a CR implant. So I usually do, if the tightness is persistent in flexion after this ITB release, I usually do this sliding osteotomy.
All right, so you have a post-op X-ray?
This is supposed to be X-ray.
All right, any critique? Fixed it with screws, it looks like? You fixed the epicondyle with a screw? 2 screws?
Yes.
So, Rajesh, what do you think? He did a good job?
Yes, looks good. Overall alignment, probably not too much from midline, so that's good. The femoral component, I don't know whether it looks hyperextended or it's just the X-ray view. But yeah, I think this looks okay to me. I would have replaced patella as well.
He still hasn't, shown us a merchant view.
That's correct. No.
How do we know where your patella is?
Oh yeah, we don't have that view here, but it does look okay on the lateral view.
All right, what about the overall alignment on the long leg?
So I think overall looks okay to me. I don't think there is. The tibia is in a little bit of valgus, femur in a little bit of varus, but overall alignment appears okay.
Yeah, I think the tibia is a little bit of valgus. I'd prefer to have that a little bit more towards the varus side, but certainly nothing that's making me overly concerned. All right, anything else you need to show us?
Nothing.
Thank you.